the most powerful predictor, the strongest association by far and away is the HDL and triglycerides. And that is the one that is the most affected by diet, specifically carbohydrates. So if you reduce your carbohydrate intake, you can reduce your triglycerides and raise your HDL, which is extremely, extremely powerful in predicting heart disease.
Hello, everyone. My name is Lisa Chance, and I'm a fasting coach here at The Fasting Method, and we are here today with our very own Dr. Jason Fung for our monthly Q&A. This is a monthly Q&A with Dr. Fung, where he answers questions submitted by our TFM community members. So hello to our podcast listeners that will be able to listen to this a few weeks after our community members. All right, so I'm going to dive right in. Good morning, Dr. Fung.
Hi, good morning.
It's great that you're here. I've got several questions for you. One is, are there common strategies that help to avoid the pitfalls of Ramadan, late night eating, overeating, or accidentally doing OMAD for too many days in a row and slowing down the metabolic rate?
I mean, just the usual precautions you have to take about overeating. The main thing is, a lot of people during Ramadan, you don't eat during the day and then you eat at night. So what happens is that some people tend to prepare a huge meal and stuff, which is sort of one of the big pitfalls, right? Because if you're not eating during the day, you're allowing your body to use up the calories, but then eat a huge meal at night with lots of sugary stuff and refined foods and so on, then you're sort of undoing a lot of the good. So you want to eat as normally as possible. So it's the same idea, like just try to make it a routine. And the good thing about doing it for a month is that if you can do it for a month, then it sort of establishes a new habit. Eating late at night is not a great idea anyway, so it's good to try and keep that as low as possible because, of course, you eat all that and then you go to sleep. Well, what is your body going to do with it, right? It's difficult for it to do anything other than store it, which is the problem.
Yeah, that's my pitfall. When I eat late at night, Dr. Fung, that's when I gain the weight. And when I stop eating late at night, that's when I lose the weight. So for me, it's a big one of the 5 pillars. This next person has several concerns about the off-label use of GLP-1 receptor agonists. And I broke it down. It was a long question. And so I broke it down into 5 points. So I'm going to address them one at a time and have you answer or comment on them. The first one is medical professionals are using and prescribing these medications for anti-aging or longevity purposes in people who aren't overweight or diabetic. Do you have a comment on that?
I don't know that there's a lot of data on that. So the whole of longevity medicine, honestly, has very little actual evidence. There's a lot of potentials, but it's very hard to do studies because you don't want to treat somebody who's 40 and then follow them for the next 40 years to see whether it worked or not. So it's just difficult to do studies on it, which leads to a lot of people saying that this is great for longevity. But, most of the time it's like they're either trying to sell you something or just trying to get you to do something else. So if they're saying that, oh, we're doing it for longevity, then you really have to be a little bit more careful about what the claim actually is. There are some studies. You can do a biological age, which is this sort of artificial measure of what your age is. And you see this on social media sometimes. There's a few of these longevity experts and so on. And what they do is try to do this biological age and see if it reverses. And there's some data with fasting, specifically the fasting mimicking diet. So the way they do the fasting is sort of a 5-day modified fast once a month. And there's some data that you can reverse that. But with GLP-1s, I haven't seen any of the data that says that it reverses biological age. But keep in mind too that, it's a surrogate endpoint, right? So they do a bunch of measurements and from that they interpret what your age is, but it doesn't actually mean that's going to translate into a longer life or whatever. So it's better than nothing, I suppose. But the GLP-1 agonist, Could it work? I don't know about the microdose. I mean, I think a lot of the issues are driven by hyperinsulinemia. So if you're taking a regular dose of GLP-1s, I think that if you have hyperinsulinemia, then it's going to be better, right? So this is the thing, right? So GLP-1s, they suppress your appetite, they reduce insulin because you're not eating much. When you eat, insulin goes up. So therefore, if you eat less, insulin's going to go up less. So it's a great drug to reduce hyperinsulinemia, which is the same thing as insulin resistance. If you look at the prevalence of hyperinsulinemia in US adults, it's probably like 50 or 60%. It's probably higher, actually. So therefore, since most adults have hyperinsulinemia, when you treat, an unselected population with a drug that lowers insulin, since half of the people probably have too much insulin, you're actually going to see a benefit. So could it work? Oh, absolutely. And this is why you're starting to see a lot of this data with GLP-1s in terms of renal protection, in terms of heart protection. So they'll say, oh, it reduced heart failure, even people without diabetes. It's like, yeah, because they had hyperinsulinemia, which is a much earlier stage than full-on type 2 diabetes. So could it work? Absolutely. I just don't know that there's any data in it. So I don't see any problem if you want to do it. But again, I would be careful. If, for example, you measure your C-peptide or hyperinsulinemia or prediabetes or have one of these measures that you're really sure that insulin is high, then lowering it makes sense. And that would be expected to, make you better.
You covered the second question here, which is on preventative health. So I'm going to go to the next one, which is potential unknown short and long-term side effects are more coming to light.
There's more coming to light because more people are using it. There have been so there are rare side effects, right? And you don't see those until you start to put them into widespread practice. So there's been a few that have been mentioned in the news. What Ozempic does is basically slows down how quickly your stomach empties, right? So it slows everything right down. So some got bad constipation, for example. And by slowing it down, you keep people from feeling hungry because everything's just sort of sitting in the stomach, right? So you feel full, you can't eat. So that's how it works. The problem is if it goes too far and you get complete stasis, that is your colons, your stomach is not moving, it can be actually dangerous, could be a life-threatening situation. So there's been case reports of that. And there's also been, I think, something like 86 deaths that have been reported due to side effects of Ozempic. I saw that in one of the newspapers in the UK. So keep in mind that when you compare that to the millions of people who are using it, it's still a reasonably safe drug, but it's not free of side effects. So this is the thing you have to keep in mind. If you have a disease where you're going to be expected to benefit, so if you have diabetes, if you have prediabetes, if you have hyperinsulinemia, which is a lot of people, there's a good reason to think that that will improve things. Then you can take the risk of side effects, right? And they're relatively rare. If you're just using it, if you're 20 years old and just trying to lose a bit of weight, which is where we're seeing a lot of the growth in people using it, right? Oh, I need to lose 5 pounds because I want to look better. So giving the Ozempic. Well, then it doesn't make sense because you're treating a lot of people who are not expected to benefit. So the risk benefit ratio really changes. It's more risky than anything else. So, short and long term side effects, yes, there's a lot of side effects. That's already known. There's rare, serious side effects that we're starting to find out. But in general, it's a relatively safe medication.
It was in the UK. I'm not sure where there was a ophthalmology clinic, and they noticed that their people were getting blindness, and then the common factor was that they were all on a GLP-1. I'd have to do more research on that. I can't even quote where it was. I don't remember if it was the United States or UK or what.
Hi, this is Dr. Nadia, and I am so excited to be hosting the Fat Fast Masterclass once again. This is a 3-day masterclass. On day 1, we will be talking about what is a fat fast and why is it so effective. On day 2, I will go over how to fat fast with you. I will be giving you a omnivore fat fast list and a vegan plant-based fat fast list. And on day 3, we will be finally talking about when to fat fast. I will also be with you for 3 live Q&As where I will answer all of your questions, as well as join you in the exclusive forum where we can chat daily. I am so excited to go over what to eat with you and why fat fasting is the most appropriate fast mimicking diet. See you there.
The next part of this question is, what ethical concerns around supply issues? People with diabetes or obesities, the struggle with that due to increased demand for off-label use.
Yeah, this was a bigger issue probably a year ago. So there wasn't enough for the people who used it for diabetes because all the people were using it for weight loss. So they allowed, I think, some of the compounding pharmacies to make GLP-1s and stuff. It's more or less over. So about a year and a half ago, I had people who would come back and say, oh, my pharmacy said they're out of it. So they just couldn't get it. But I haven't heard that for like 6 months. And the reason, of course, is that the drug companies make a lot of money by selling drugs, and you can only sell a lot of drugs if you make a lot of drugs. So they've invested very heavily in making these drugs available. And so that concern was an important one, but it's probably mostly faded now. I think if anybody who wants it can more or less get it. The bigger issue is the cost of the drug. They're making huge profits on it. So is that ethical? I mean, that's a different debate as opposed to availability. The availability part is more or less solved. And honestly, I think it's only going to get easier to get the drug from here. There are newer drugs. There are other companies jumping into the space. So, there's Ozempic, there's Mounjaro, but every company, practically every drug company on earth is looking to bring their own out, right? It's sort of like how statins did. And, every company had their own statin. Eventually, one or two will end up being used heavily, and that's about it.
And the last part of this question, what are the bioethical considerations that doctors should practice when discussing going on a GLP-1 receptor with a client, with a patient?
I think it's all about risks versus benefits. And I think that certainly it's a reasonable drug in a lot of cases. So type 2 diabetes and so on. It's better than insulin, for example, right? So it's a much better drug in terms of how it's used. It causes weight loss as opposed to weight gain. So it's a lot better than insulin, right? But on the other hand, if you're not using it for those reasons, then what's the risk versus reward benefit? The other thing, of course, is the weight regain, right? So if you take it, you lose weight. If you stop it, all that weight comes back. So if you're going to take it for the rest of your life, like some of these type 2 diabetics will, obviously diet is the best thing if you can. If you can't, then it's still better than not taking it, right? But are you going to take that for the rest of your life? So this was the big thing about the pediatrics. So it sort of blew a lot of people's mind that the American Academy of Pediatrics basically said, you should consider it for anybody over 12. I'm like, what? You're going to put a 12-year-old on drugs for the rest of his or her life? Are you serious? That doesn't make any sense at all. And they had some rationale, but most of the rest of us were like, man, they must have been donating a lot of money to the American Academy of Pediatrics to get that kind of endorsement. And of course, the problem is that there was no studies saying that it was useful in children in any way. So they basically made it up, and pretended it was supported by evidence when it wasn't. So yeah, the ethical concern is mostly around people who don't have a good indication for it, because everything's risk versus reward. So say you take it, you're 15 years old, you take it and then you stop it, and what good have you actually done? Like, have you gotten any good? And if you haven't gotten any health benefit, could you have used that money that you spent on Ozempic on, weight loss programs, or, there's a huge amount of other things you can do, exercise programs, gym memberships, right? So there's a huge amount of other things you could do with that money instead of drugs, right? You can try and do, get people counseling, you can get them cognitive behavioral therapy. There's so many other things that are useful, that take time, that take money. And if you're taking it away, there's an opportunity cost that's taken away. So yeah, absolutely. I don't think that it's the right answer in every single case. I think that it does help a lot of people, but it's at this point in that sort of, we just way overused it in people. Like you take the group of people who benefit, you extrapolate it to the entire population, right? And it's like there's no benefit when you give it to everybody. Anyway,
I have several clients that are on it, and I like what Dr. Ben Bickman has said, which is when you use it as a bridge.
yeah.
And so they use it as a bridge and they practice the things we teach, which is time restricted eating and no snacking, getting your insulin down, learning how to fast, and then they can make that transition on over because they've changed their lifestyle.
Yeah.
And as you said, addressed these cognitive behavior issues. So, yeah.
Exactly. That's exactly how you should think of it because you learn all this stuff, you build in the healthy habits that are now going to sustain you, then you gradually pull back. And then you don't have that weight regain once you do it. And that's a very reasonable thing to do. Makes a lot of sense to me. But if your whole game plan is take this drug for the rest of your life, and sad to say, that's like 95% of doctors out, that's how they prescribe it, then no, it's not that useful for people.
Thank you, Dr. Fung. This is my question. I slipped one in here. In the March issue of Diabetes, Obesity, and Metabolism, they had an article entitled The Rise in Prevalence of Obesity in Youth with Type 1 Diabetes. And it got me thinking, all right, would you address how type 1 diabetes can develop into insulin resistance similar to type 2 diabetes, sometimes referred to as double diabetes?
Yeah, that's a good question. So type 1 diabetes is, in fact, opposite of type 2 diabetes. So type 1 diabetes is too little insulin, type 2 diabetes is too much insulin. What's striking is that the prevalence of type 1 diabetes, not just in kids, but also in adults too, has gone up substantially in the last few decades. It used to be extremely rare. So if a kid had diabetes, it was almost always type 1 diabetes. Now it's sort of half and half type 1 and type 2. And that's only because type 2 has gone up so much. Type 1 itself has actually gone up, but not as much as type 2. But the question is why? So type 2 is a dietary disease. It's often related to carbohydrates and refined foods. But type 1 is an autoimmune disease. So it's your own immune system that's attacking the pancreas and therefore not producing enough insulin. So why is that going up? And that's a good question. Nobody really knows the answer to that. And it's the same as, say, gluten sensitivity, celiac disease. That's also an autoimmune disease, the prevalence of which is going way up. And some people might say, well, it's just because you're recognizing it more. And for celiac disease, no, it's not, because they've done a study where they went back into some old blood work that they had on people. I think they're in the Korean War or something like that. They drew everybody's blood. They had archived it. They tested it. And sure enough, there just was not a lot of celiac disease back then. And now there is, right? So that's why gluten-free is a much bigger thing, because a lot of people actually do suffer from this. Same as type 1 diabetes, it's a real increase. So for some reason, there's something screwing up the autoimmunity and nobody really knows what it is. So type 1 is going up. The thing about type 1 diabetes is if you look at a normal person produces probably around 15 units of insulin per day. So a type 1 diabetic who's newly diagnosed, he only needs a bit of insulin, like 10, 15 units a day. The problem is over time, they develop insulin resistance. So then they need not just 15, they need 20, 30, 40, 50, 60, 70 units. And they keep getting all type 1, but they actually have both type 1 and type 2. So they have type 1 because their own pancreas produces no insulin, but they have type 2 because all that exogenous insulin, they actually have hyperinsulinemia. So remember, what insulin does is it tells your body to store sugar, as store calories, tells you to store it as body fat or store it as sugar, like glycogen. And if you're taking too much insulin with too much sugar over time, even if that insulin comes from the injection as opposed to your own pancreas, you do get this insulin overload, which is type 2 diabetes. So now you have type 1 diabetes and type 2 diabetes, which is double diabetes. So in a sense, you have both type 1, which is increasing over time for an unknown reason. You have type 2, which is increasing for a dietary reason. And then you get that double diabetes. It's just all over bad news.
I've been working my way through your interviews, your conversations with the Fasting and Longevity Summit 2.0. I noticed you're not called Brad anymore. So, so congratulations on that, fixing
Yeah,
that with
that was
YouTube.
something.
But I loved your interview with Dr. Tro, and I can't say his last name. He talked about the type of calories that we're consuming is what is leading us to wanting more calories, usually more problematic type of calories also. So I'm going to put the link to that in the podcast show notes. But he also went on to address these things like you were talking about autoimmune, and it was a really good interview. I really like that. It's so neat to see you asking the questions.
Yeah, it's cool.
Yeah. So this person would like you to talk about LP little a and how concerning is an elevation in that lab level and how to lower it. And is there a relationship between the gut microbiome and small particle LDL?
So LP little a is supposed to be, so we measure in the cholesterol panel the LDL, which is always considered the bad cholesterol. Technically, it's not a great term, but when it's high, that's what people focus on. Then there's the HDL, which is the good cholesterol, which is, again, you want it to be high because it's good, right? And LDL is bad because it's bad, so you want it to be low. That's how the standard cholesterol panel is set up. It's not ideal. So they do this lipoprotein A, which is really looking at a more specific marker of the sort of bad cholesterol particles. So when you do association studies, it appears to be more powerful than the LDL. So it may be useful. So can you lower LPA? There actually was a new drug that just got tested, which showed that you can actually lower it quite significantly, right? So we're talking about if you lower LDL, so statins, for example, you lower everything. You lower LDL, you lower LPA, you lower HDL too, which is probably why it's probably not as good as people think it is. So that's sort of interesting because what you have to do is you have to lower the LPA and then see if they survive longer. So they're only at step 1 where they've given the drug and they're like, yes, we can lower LPA. Now you have to say, does that actually do any good? Because remember, if you think about the cholesterol panel, there's 3 things. There's the HDL, the good cholesterol, which goes with the triglycerides. So triglycerides and HDL is sort of their opposite, right? So when triglycerides go up, when you eat a lot of carbs, triglycerides go up and HDL goes down, right? So there's the HDL triglyceride, there's the LDL, which is the statin, and then there's the LPA, which is that new drug. So the most powerful predictor, the strongest association by far and away is the HDL and triglycerides. And that is the one that is the most affected by diet, specifically carbohydrates. So if you reduce your carbohydrate intake, you can reduce your triglycerides and raise your HDL, which is extremely, extremely powerful in predicting heart disease. What if you just give a drug to lower HDL? Well, they've done that. It lowers your HDL just fine. The problem is that you die more frequently. So it did do nothing. And why? Because you didn't actually change your diet. HDL was just a marker of having a good low carbohydrate diet, probably not having all that hyperinsulinemia. LDL, we gone ad nauseum about statins and LDL, and then LPA. Does diet affect LPA? Not really. Same as LDL, not really. That's the thing about LDL and LPA is that it's like a drug maker's dream because if you have a high LDL, there's almost nothing you can do from a dietary standpoint to lower it. So what do you have to do? You have to take drugs. All you have to do is convince people that LDL is the sort of be all and end all of everything. And then you can get them to take drugs because there's actually nothing they can do. Diet, lifestyle, exercise. I don't care what you do. You probably won't change your LDL much. The only way you can actually change it is with the drugs. So it's a drug maker's dream. And the funny thing is that I pointed out on Twitter, there's been 2 studies in the New England Journal of Medicine, which is the most important journal in medicine, actually. It's the most prestigious. One just a few months ago and one I think last year. And they looked at risk factors for heart disease. So they looked at 5 risk factors basically, and they say, well, what if we reduce smoking? How much, how many years of life can you save and all this sort of stuff. And the super interesting thing is that all these things that were important, stopping smoking and all this sort of stuff, all of them showed a real benefit, but the one thing that didn't show practically any benefit was lowering of the LDL cholesterol. So this is that new study. So I tweeted out, let me just see when I did that, April the 2nd. So if you stop smoking, you'll save about 5 years of life. If you have diabetes, if you get rid of it, you'll save about 4 years of life. If you control your blood pressure, about 1.3 years of life saved. If you lower your cholesterol, you'll actually lower your life expectancy by about zero point 0.4 to 1.3 years, which is like insane. So all these other things, stopping smoking, diabetes, blood pressure control, they all help you. But the one thing that doesn't help you is actually lowering your cholesterol, which is like, wow. I don't know why more people didn't think, oh, this is really an important thing, but nobody else seems to care in the medical field, right? Like we point stuff out like this, even when it's in the New England Journal and it doesn't get any traction because everybody's so brainwashed and thinking that it's all about the LDL. I'm not saying that statins have no place, but I think their place is just like the sort of Ozempic. It's just been expanded because you could treat it. It became this sort of everything is cholesterol when it's like, it's only about as a risk factor is like this important compared to diet, which is like much more important.
Do you know of research or trials with fasting being used to reduce prostate size? And also, is there a medical database that this person could subscribe to so they could keep track of any research studies being done on that?
Don't know of anywhere that you could go. The only thing I do is just if that specifically is what then I just search it every so often. The best place is to search is PubMed. What I would put in as a search term is something like fasting and prostate size, comma, PubMed. That way you don't get all the sort of other stuff that other people write and you just get the studies. And they're pretty good. Like PubMed has a lot of stuff, right? So if there's any studies and they'll go back, many years, there's not any that I actually know of because remember, fasting hasn't had a lot of data in it. It's possible, though. I actually think that a lot of these may require regular fasting. So, fasting, there's this whole thing about autophagy and also, not just that, but insulin is not just a metabolic hormone, it's a growth factor, right? So if you have hyperinsulinemia, the thing is that you may have a lot of these other growth factors being increased. And one of them could affect the prostate size, obviously, because let's say you just don't want it to grow. So if you have insulin, which is a growth factor, then high insulin is going to lead to more growth. So therefore, it makes sense that, hey, this might be an intervention that was very useful. But that's just a hypothesis. I don't have any proof that actually happens. On the other hand, if you wanted to wait for the proof, you might be waiting like 20 years, in which case you might not be worried about your prostate at that point, right? 20 years is a long time to wait. So the whole thing is that at some point you have to say, wow, either you just go ahead and do it and hope for the best, or you can wait for that data because that data it takes time, it takes money, it takes people who are interested in fasting. I mean, the initial fasting studies that were done were just really bad. They were like, oh, fast on one day and eat double the next day. I'm like, okay, well, that's not going to give you very good results. Like, you don't have to be a genius to figure that out, right? You're not going to do very well. So, of course, they didn't do very well. And they said, fasting doesn't work. It's like, no, you did it all wrong. When are you supposed to allow your body to use up your calories if you're just going to double up the next day? So anyway, the whole point is that I would just check it on PubMed. That's the best thing to do. And then you'll find everything you need.
Thank you. I'm navigating this question carefully because I don't want it to be a medical question, but this person would appreciate your opinion on somebody who's a 65-year-old woman who's considering donating her kidney. Would fasting or fat fasting help around that time period?
It can. It doesn't affect the kidney function so much. So fasting is good for a lot of things. The kidney isn't probably one of the ones that gets affected a lot. I mean, in chronic kidney disease, we've talked about CKD, there is a study on chronic kidney disease and fasting. And it was from the fasting mimicking diet people, because again, because they have a product, they're actually more interested in sponsoring research on it. So a lot of research is starting to come out from them. And it does reduce chronic kidney disease. Of course, it can reduce diabetes, both of which are important. If you're going to donate your kidney and you have diabetes, you will get turned down right away because people are like, well, you have diabetes, your kidneys will be at risk in the future. So we can't take your one kidney because you could need it in the future. So it could help certainly around that by reducing the sugars. And then again, if you have any kidney disease at all, they will refuse to take that kidney as well. So it could be worthwhile to get those sugars right down and also help to preserve the kidney function.
And fasting increases your glomerular filtration rate too, doesn't it? I don't know if that would help with the kidney transfer.
Yeah, I mean some of the data is the glomerular filtration rate is basically how well your kidney is working. So most people are normal, so it doesn't matter how much you are filtrating. But if it starts to go down, then when you get kidney disease, you'll see a lower filtration rate, and that's where fasting can sometimes help with that actually. So that can be useful.
And by the way, I get a lot of people who send me articles for you to read. That doesn't work that way, you guys, unless he's already read it. But they were wondering if you had read the latest article in the New York Times about the processed seed oils. It seems like this is coming up for debate again. And, they're saying they have seen multiple reputable sources. I personally questioned the type of research that they're doing. Is it questionnaire or or is it randomized control study? Do you have anything to say about seed oils being avoided on account of them being more processed rather than something like olive oil or butter?
Yeah, so this one is actually an important one because seed oils are highly, highly processed, right? The problem when you process stuff is that you purify certain things, in this case, the polyunsaturated fats, right? And the problem with polyunsaturated fats is that because there's a lot of unsaturated bonds, they're less stable than saturated fats. Because they're less stable, they're prone to oxidation and stuff, which then if they become oxidized, then they could cause a lot of inflammation. So everybody thinks they could be highly inflammatory, which I think is certainly possible, but it's always hard to put a link one to one with it. You can do studies linking, say, linoleic acid and polyunsaturated acids to certain diseases. But when you do it over large populations, then everybody does it differently. Everybody's eating different seed oils and stuff. So you have a potential mechanism, which is plausible. That is, too much of this processed seed oils gives you too many unsaturated, which are unstable oils, which leads to increased inflammation. So that's a very plausible hypothesis. The problem is going from that hypothesis to actual proof is much more difficult. It takes a lot of studies, and the studies are sort of like here and there. So there are a lot of people who say that eating a lot of vegetable oils is good. And now there's a lot of people saying that eating a lot of vegetable oils is bad. To me, it's very hard to argue because the data is just so sparse in terms of actual causal data. So it's hard to say that it's true and it's hard to say that it's false. So in that case, I always fall back and say, well, what's the smartest thing to do for myself? Well, the smartest thing would be to eat the oils that have always been eaten. So if you look back and, what have people naturally eaten? What are the natural fats? Olive oil has been used for thousands of years. Coconut oil has been used for thousands of years. Butter has been used for thousands of years. So those are what I eat. Vegetable oils have been around since about 1900. They really increased a lot in the 60s, 70s, 80s. Around the same time, you saw all these autoimmune diseases popping up, right? So is it plausible that the seed oils are causing inflammation, which is causing all these autoimmune diseases, which is inflammation, right? Inflammatory diseases. Yes, it's possible. I don't know that it's true, but what do I do? Am I going to wait 20, 30, 40 years? In 40 years, I really won't care. It'll be way too late for me So what do? I eat butter, I eat coconut oil, I eat olive oil because those are natural fats that I know people have eaten for a long time. So I'm pretty sure that they won't be harmful to me. I'm not so sure that eating a lot of vegetable oils is bad for me. I actually think that there's two things with vegetable oils. One, I try not to eat too many. And two, I try not to eat them in fried foods. Deep fried seed oils are probably the worst thing you can do because the oil is not stable, chemically stable. Like you can argue a lot of things, but if you look at saturated versus unsaturated, unsaturated is much less stable in heat. So when you do high temperature seed oils, like deep frying your foods in seed oils, if it's going to be bad, if the seed oil is going to be bad, the high temperature is going to be like 10 times as bad, right? So putting a little canola oil in your dressing, I'll accept that if I have to. I try not to. I almost always use olive oil, but deep frying in vegetable oils is like super bad for you. So when you go to McDonald's, when you go to any of the other places, yeah, the deep fried foods are probably bad for you, but it might not be bad. It might have been the seed oil and it might have been the fact that it's deep fried. So those are the things to really watch out for. So to me, it's like I can't make any 100% this is what's true, this is what's not true, but I can only say that what I think is the most logical path is to avoid deep fried seed oils, definitely. And then seed oils, I try to limit, but it's not always possible. Like other people use it, and I'm not going to say no. But if you look at what's in my kitchen, I have olive oil and butter for practically everything. I would use coconut oil, but my kids actually don't like it at all, so they won't eat anything. It has a strong flavor. I love coconut, so I put
Me
coconut in
too.
everything. But yeah,
It helps my migraines too, I think.
yeah,
I think it's because it's a saturated fat. I think it helps my migraines. So that's a whole
yeah.
nother story. Yeah.
But really, it's all butter or olive oil in my kitchen. And I don't have any problems, right? I don't deep fry. I use the air fryer more just because it's a lot easier, but I pan fry stuff and they have this new olive oil that you can pan fry in. I do butter. I don't do high temperature cooking. It's not that hard, right? To get away from that almost entirely. I haven't bought vegetable oil in like 10 years.
I use avocado oil also. And what shocks me is I read some of these studies and they're still putting all these oils together, like avocado oil and olive oil, in with the studies of the seed oils. And it's like, no, you need to separate those
Yeah.
out.
Yeah. I think avocado oil is fine too. It's just that I'm so used to olive oil now. There's a little bit of flavor with the olive oil, so I like that. And I think olive oil is just more easily available, but avocado oil is great too. But really to me, it's like I'd say 80%, 85% of butter and olive oil is almost everything that I use is that. Sometimes I use like the drippings from beef and stuff. You get the oil and then I save it actually to fry in it. That's beef oil or whatever. But again, it's a natural fat, so that's why I save it. Or bacon oil, I'll save it and use it again.
I use bacon oil too. Even though I'm basically plant-based, I will save the bacon oil, bacon grease. Well, thank you so much, Dr. Fung. I know I kept you over this time. All righty, you guys. See you next month.